When Harold turned 72, he thought his increasing tiredness was just part of getting older. For almost 5 years he'd taken his blood pressure pill every morning without fail, trusting Drive William and never questioning the prescription. But 8 months ago his daughter began to notice changes. A man who used to walk 3 miles before breakfast now sat watching the clock by 10 a.m., exhausted. He stopped visiting the hardware store on weekends and told his grandchildren he was too worn out to play. One afternoon he stood up from the kitchen chair and his legs gave out. He caught the counter just in time. His pulse, when checked, was 46 beats per minute. Everyone assumed it was age. No one mentioned the medication. Yet the real reason for Harold's collapse was not his years, it was his drug quietly slowing his heart to a level his body could no longer tolerate. That's the question most people never ask. Between amlodipine and metoprolol, which is actually safer for an older body? The answer won't satisfy a simple yes or no. It depends on something many doctors don't always explain in a brief visit. So before comparing the two, we need to understand one fundamental truth. A 72-year-old's response to medicine is not merely a little different from their 52-year-old self, it's profoundly different. After about age 60, blood vessels lose elasticity and become stiffer. That change makes the top number of your blood pressure, the systolic pressure, harder to control, and that number is the one most strongly linked to stroke, heart attack, and cognitive decline. But blood vessels aren't the only part of the body that changes. The liver, which metabolizes most drugs, slows down. Medications stay in the bloodstream longer and can build up to higher levels. Kidneys filter less efficiently. The nervous system reacts more slowly to sudden drops in pressure, so standing up quickly can cause dangerous lightheadedness or fainting. The heart itself becomes more sensitive to medicines that alter rate and rhythm. Hold this perspective. A medication is not inherently safe or dangerous, its safety depends on the body taking it. After 60, that body has changed in important ways. Let's begin with amlodipine. It's a calcium channel blocker. That sounds technical, but the idea is simple. Calcium entering cells in artery walls makes those muscles squeeze. That squeezing raises blood pressure. Amlodipine reduces a portion of that calcium entry, so artery walls relax, widen, and blood flows with less resistance. For older adults, this action has a key advantage. It directly addresses arterial stiffness, the very problem that drives stubborn systolic hypertension in seniors. Clinical studies show amlodipine reliably lowers systolic pressure and reduces stroke risk in patients with coronary artery disease. Dosing matters. While younger adults often start at 5 mg daily, many older patients begin at 2.5 mg because the liver clears the drug more slowly and the vascular response can be stronger. The dose can then be increased slowly if tolerated, up to 10 mg. Now metoprolol, a beta blocker, works differently. Instead of focusing on the vessel walls, it acts on the heart. Beta-1 receptors on heart muscle respond to adrenaline and tell the heart to beat harder and faster. Metoprolol blocks those receptors, slowing the heart and reducing the force of contractions, which lowers blood pressure. This effect can be life-saving for people who've had a heart attack, live with heart failure, or have certain arrhythmias, because it reduces the heart's oxygen demand and stress. But dosing in older adults must be cautious. Physicians often start at lower doses, for example, 25 to 50 mg of the extended-release form, and increase only gradually with close heart rate monitoring. Crucially, metoprolol must never be stopped abruptly. Sudden withdrawal can trigger rebound tachycardia and hypertension and increase the risk of chest pain or heart events. Each drug has a distinct side effect profile that affects people differently. Amlodipine commonly causes peripheral edema, swelling of the ankles and feet, because it relaxes arteries more than veins, allowing fluid to pool in the lower limbs. This swelling isn't usually a sign of heart failure, but it can impair mobility and increase fall risk in seniors. Other possible effects include facial flushing, dizziness on standing, or mild palpitations. Metoprolol's most common complaint is fatigue. Patients describe a heavy, persistent tiredness that saps motivation. It can slow the heart too much, causing lightheadedness or fainting, and in people with reactive airway disease it can worsen breathing. The bigger danger is drug interactions. Most seniors take multiple prescriptions, 4, 6, even more, each prescribed separately and judged safe in isolation. But when medicines compete for the same metabolic pathways, one drug can raise another's level to unsafe concentrations. Amlodipine is metabolized by the liver enzyme 3-cypriot-pounds-A4, which also processes many antibiotics, antifungals, and other drugs, and even grapefruit juice can interfere, increasing amlodipine levels and amplifying side effects such as swelling and dizziness. Metoprolol interactions, especially with other heart medicines like digoxin or additional blood pressure drugs, can slow heart rate dangerously when combined, increasing the risk of fainting and narrowing the margin of safety. These interactions are not rare. They're happening daily in millions of older adults whose full medication lists have not been reviewed together. So what do the guidelines say? Major societies agree that treatment must be individualized for older adults. For otherwise healthy seniors, a systolic target below 130 mm Hg is often reasonable, but for frail patients with multiple conditions, a less aggressive target may be safer. Lowering blood pressure too far in a fragile person can cause harm. Where the two drugs sit in guidelines differs. Amlodipine is commonly recommended as a first-line option for uncomplicated hypertension in older adults because of its effectiveness against systolic hypertension and stroke risk. Metoprolol is not generally the first choice for uncomplicated high blood pressure. It's reserved for cases where the heart itself needs protection, prior heart attack, systolic heart failure, or certain arrhythmias, because those situations change the balance of risks and benefits. In short, neither drug is universally safer. The safer choice is the one that fits the person's specific heart, health history, and reasons for treatment. Amlodipine is often the better option when the main problem is stiff arteries and high systolic pressure without heart disease. Metoprolol is preferable when the priority is reducing the heart's workload or treating heart disease already present. Knowing this isn't enough, you should come to your next appointment prepared. Here are 5 questions to bring to every medication review. Based on my health profile, is this the most appropriate first-line medication for me? What side effects should I watch for in the first 4 weeks, and when should I contact you? Has my full medication list been checked for interactions with this drug? What is my target blood pressure, and has it been adjusted for my age and overall health? How often will we reassess whether this medication is still right for me, and when might we consider lowering the dose or switching? Any clinician who partners with you will welcome those questions. They show you're informed. Not difficult. Back to Harold. After his fall, his daughter insisted on a complete medication review. Dr. William examined his cardiac status, lab results, and all his prescriptions, then supervised a careful transition from metoprolol to low-dose amlodipine. The switch was gradual, closely monitored, and adjusted over weeks. Within 2 months, Harold's resting heart rate rose to a healthier range, his energy came back, and his daughter said it was like watching someone wake from a long sleep. He resumed his morning walks, returned to the hardware shop on Saturdays, and played with his grandchildren again. This isn't a miracle. It's what happens when medication decisions are made with full information, thoughtful questions, and close partnership between patient and doctor. Your blood pressure drug is not a small detail to leave on autopilot. It must match who you are today, not who you were when the prescription was first written. This video is for education and does not replace medical advice. Do not stop, start, or change medications without discussing the plan with your physician. Are you taking amlodipine, metoprolol, or both? Hearing real experiences helps the community.